Hello, I'm Dr. Becky Lynn, and I'm here with Brooke, say your last name. Kalisiak, who is a pelvic floor physical therapist here in St. Louis. I'm an OBGYN, and I specialize in women's sexual problems. And I send so many of my patients to physical therapy. So I wanted to introduce you to Brooke and have you hear a little bit about what she does for my patients and for patients in general on a daily basis. Do you want to say anything, Brooke?
Or? No, thank you very much for having me here today. I really appreciate it. And I'm excited to get the chance to talk about pelvic physical therapy because, as you've probably heard when you recommend it to a patient, that they may not have heard that it's something that they can do, and they're a little bit surprised that it's something that's out there. But pelvic physical therapy has been around for decades now and is definitely an integral part in care of women dealing with sexual issues. And that's why I'm excited to chat with you today about potential treatment options for women.
So when I send you a patient, how should I describe to them what to expect?
No, that's a really great question because I'd say 9 out of 10 patients that show up in my office sit down and are a little bit leery about what's going to happen. So any kind of explanation on the front end is very helpful. So what I usually tell people is that our pelvic floor muscles are muscles just like anywhere else in our body. So they contract, relax, they can be too tight, they cannot move well, they can be too weak. And my job is to evaluate them and see how they're moving. They just happen to be in a private area of our body. So I let them know that the gold standard for evaluating the pelvic floor muscles is similar to a gynecological evaluation. So in our situation, we usually have people undressed from the waist down. And I'm usually inserting one gloved finger into the vaginal canal. With the patient's permission, we do a lot of talking up front, especially when we're dealing with painful intercourse. There's usually a lot of times some anxiety around it. So that may or may not happen on the first appointment if the person's not comfortable with it. It typically takes maybe about 5 to 10 minutes depending on what we're looking for. It's all completely under the patient's level of control. And at our office, I'm talking through it the whole time with them, asking for their feedback as to what they're feeling and also if I'm okay to proceed. Because a lot of times, especially again when we're dealing with pelvic pain, there's a fear component to it that this is just going to get forced on me, this is just going to keep hurting, and I'm letting them know over and over again that we do not need to force through pain to help try and get you feeling better. So I'm trying to make them as comfortable as possible. But that gives us, that internal examination really gives us the most information about what's going on with the pelvic floor muscles and lets us kind of come up with a detailed treatment plan to move that patient forward.
So if I have a patient, and I see many patients with pelvic floor muscle spasm, either alone or it tends to travel with things like endometriosis and interstitial cystitis, sometimes vulvodynia, irritable bowel. But let's say I have somebody who I diagnose pelvic floor muscle spasm and I send them to you. What are your goals of treatment and what are the methods that you use to accomplish those goals?
That's a great question. Goal-wise, we always try and tailor it to what's the patient's goal. You know, are they coming to us because they're unable to be intimate with their partner and because of pain, and so is that our focus? Or is pelvic pain affecting many aspects of their daily life? So are they having difficulty having bowel movements? Are they having pain just in their day-to-day activities, or they can't work the way that they want to be working because they're dealing with pain? So up front, we're doing a lot of talking with the patient to figure out, okay, what's your main focus? With the evaluation, we'll see where we're having the problem areas all around and but then we'll prioritize it based on what the patient's main needs are and kind of work down the problem list that way. When it comes to deciding what's going on with the treatment, again, a lot of it's based off of the evaluation, and we just described how we would evaluate the pelvic floor muscles themselves, but it's also very important to evaluate the whole body. So our examinations actually start with kind of what I call a movement evaluation, where we're just seeing how the patient is moving kind of from head to toes paying particular attention to what's going on around the pelvic area. So, you know, what kind of stiffness or movements do we have around the back, the hip, the abdominal muscles? When we move certain ways, does that change the pain that they're feeling? Because especially like you said with kind of all of these, not extra, but if we're dealing with endometriosis, constipation, interstitial cystitis, all of these extra diagnoses that are there, that can affect all sorts of different parts of the person's body and how they're moving. And when we've been dealing with pain for especially an extended period of time, it really changes. People tend to change how they move and how they support themselves and use their muscles.
So I know that many of my patients will end up using dilators. So 2 questions. Do you use dilators in your practice? And if you do, how do you teach them to a patient? How does it work to help relax those muscles? Of course, in conjunction with all the other things that you do.
Yeah, so vaginal dilators can be a very helpful resource for someone who is dealing with pelvic floor muscle spasm, maybe scar tissue in the vaginal canal that's limiting motion, or just someone who maybe has a fear response to any type of vaginal insertion, whether it be tampon, whether it be gynecological exam, or potentially being intimate with a partner. So vaginal dilators are very helpful to introduce gentle stretch and change to the tissue in a very controlled way for the patient. So ultimately, they are kind of conical in shape and they go up in size, closer and closer to more erect penis size. But we start with very much a small size. Usually most of my patients are starting with one about a finger size and working towards one that's closer to ultimately what their goals entail. So for some, it's just that they want to be able to have a pain-free gynecological exam every year because maybe they're not sexually active currently. And for others, they're like, no, my partner is this size and I need to be able to tolerate that. And so it lets us set it up in a very controlled and structured way where on a repetitive basis, the patient can introduce touch and sensation to the vaginal canal without it being painful. So the goal is never to force through pain with the use of the dilators. It's to slowly introduce more stretch and give to the tissue. And so the time frame of using dilators varies depending on the patient. I have some people who, kind of in a couple weeks sort of progress right through them, and I have other people who've worked with them for months, and that because of the severity and chronicity of what they're dealing with. And sometimes we're using them in the clinic, sometimes we are just using the time in the clinic to educate the person on how to progress it at home, but it's definitely something where time and repetition become very important with the use of those.
So I see many women with anxiety about painful intercourse, and we can work on relaxation of the pelvic muscles or using the dilators to get comfortable with something in the vagina, but mentally, what kind of relaxation techniques do you teach them to help them relax and not just automatically have the whole body tense up during intercourse?
There are a lot of different techniques that we can use. I am a big proponent of just using deep diaphragmatic breathing to help have a calming effect on the nervous system and our whole body. It gets the pelvic floor muscles to move, so I always go to that with like 100% of my pelvic pain patients. We're working on that skill because quite honestly, the vast majority of the people can't do that very well. And then they need to be taught how to deep breathe. We women especially are very good at breathing up here in our chest and never letting our belly move at all. And so
as I sit here,
as we're sitting very upright and probably holding our bellies in and that. So, needing to teach them how to let go and let the belly and the pelvic floor move with that. So I go to that first and foremost. I often recommend, whether it be finding some form of guided meditation for people, and I give some suggestions. There's some different CDs and that I do recommend for people. I love there's a free app called Calm.
I've heard of that,
and you can get it on the website too, calm.com. What I love about it is you get to pick your nature sounds. So I'm a mountain stream. I love that. That's my peaceful sound, but it has ocean waves or up in the clouds or But so you can just have that in the background, you know, when you're practicing your dilators or that. And then also they do have, the app itself has different guided meditations through it. Some of them are free, some of them you got to purchase or that. But that's one of my go-to ones that I recommend for patients. And then, you know, picking stuff that's pertinent to them. So if they have music that they love to listen to, or they have scents, you know, a candle that they really love the scent on. You know, it's like when we're trying to put the nervous system at ease and put it into a happy place, it's like, all right, let's make this little kind of happy place that you do this in. Like you always are practicing this in, you know, your guest bedroom or wherever, and you have your candle, you have your music playing and that, so that things are, you start to get that nice kind of happy muscle memory and associated with it versus, you know, the potential pain aspect with it.
I really like that idea of using what calms the person, not just the, you know, comfortable music playing in the background, but the smells. And because I almost feel like after a while, if they were triggered by that smell or that sound, they would automatically relax. And I wonder if you couldn't even play that music like the first time they try intercourse after they've been working with you for a while and they're ready and they're comfortable to put those things in the background.
I definitely
like
recommend
that
a
idea.
lot. Yeah,
that's great.
Yeah, so they can start having that positive association with it, and then when it comes time to transition, it's like, okay, that stuff still happens ahead of time and so that you have that there. In the clinic, I'd say one of the things that we sometimes use with people to help them become aware of what their pelvic floor muscles are doing is biofeedback.
How does that work?
So biofeedback, there's a couple different types, but basically we're using sensors, and so the sensors can either be outside on the skin, so they'd go on either side of the anus. That's because that's where we can get at the muscles the best, not because we think the anus is part of the problem. And just clarification. Or there are internal vaginal sensors, so if a woman can tolerate some insertion, we can use that. Sometimes that's too much off the bat, and that. So I actually err on the side of using the external sensors for most of my patients, just for comfort level and a little bit more ease of doing. But what they do is they pick up the electrical activity of the muscle, and so our nerves use an electrical signal to tell our muscles to either tense up or relax. And so the machine picks that signal up and lets us get a picture of what the pelvic floor muscles are doing. So we get a little line graph or a bar graph going on. And so some people have a really hard time knowing what their pelvic floor is doing. It's not like your bicep. You can't tell like, oh, hey, I just contracted it and now I let it go. They really, for one, they might not have ever even known they had muscles there, and so didn't even realize that they may be clenching them tight. And so the biofeedback lets us give them a visual, and then they can kind of match that up. Like, hey, oh wait, I thought I was relaxing my muscles, but the line graph is going crazy up here and that. And so we can have them hooked up to that and looking at it and working on some of the techniques like deep breathing and that, just to see, okay, now when you're doing your deep breaths, look what happens after 5 deep breaths, like you're already calming it down. We can also take that a step further, especially when we use the external sensors, is like, okay, I'm about to try and touch the vaginal opening with my finger. I want you to see what happens to your pelvic floor when we apply the touch to the area. And so sometimes they're like, I didn't even realize that my muscles tense up like that. And so again, we work on, okay, we're going to touch, but what can we do to keep that line nice and steady and low? So it's not something that we use with every patient, but with some people who don't have a great awareness of what their muscles are doing there, that can be very helpful to help them kind of see and match up what they're feeling to what they're seeing. Kind
of like when you're in labor and you're like, is that the baby moving or is that a contraction?
Yeah.
But if you were on the monitor, you'd be like, oh, that's not the baby
that's
moving.
Not the baby
that's
right now. yes, definitely like that. Yes.
Because uterus is just a big muscle, so very similar. So along that same line, what about people who might have like a scarred episiotomy? How do you work with them to help get rid of the scar tissue?
Yeah, so I see a lot of women in that first year postpartum who are dealing with some type of pelvic pain issue. Oftentimes that first time they get the green light at 6 weeks, everything's healed, let's go back and be intimate with our partner, and they try and it hurts like heck. And Unfortunately, a lot of women, I've heard them been given the advice that, well, you just had a baby, have a glass of wine and relax, and it'll get better. And so they get that medical advice and they try again and it still hurts. And so they're very discouraged because now they don't know where to go to, because they're like, well, I called my doctor's office and they said that, it's me, I should just relax. But what really I see a lot in those patients is that they've got scar tissue that's not moving as well. Whether you had an episiotomy, which is where they cut down there to make room for the baby, or you tore naturally and had to, be stitched up a little bit to heal.
Which is how most people end up. By the way,
yes,
episiotomies they're becoming a thing of the past. We do them when we have to get the baby out quickly. So just to put that out there, not to scare everybody.
No, definitely. And but scar tissue is a natural part of healing too. Right. We all develop scar tissue when we injure ourselves, and it's a natural part of healing. And scar tissue responds to stresses that are put upon it. So if I fall down and scab my knee, in the beginning, my knee's going to be pretty stiff as that scab's kind of healing up, okay? But I keep walking, I keep moving, I keep doing what I need to do, and that scab and that scar gets movement to it on a daily basis, multiple times a day. And so it learns, like, oh, okay, wait, I need to be able to move this way, and the scar tissue actually lays down very smoothly to allow the knee to move.
Right.
When we have a vaginal scar from the vaginal delivery or from episiotomy or that area doesn't get a lot of movement afterwards, and actually we need to let it protect and heal. But then oftentimes the first attempt at more movement there is vaginal penetration from a penis, and that can be a very big stretch to the tissue there, and the scar might not be able to move that much. It might be kind of stuck down. And so what we do in that situation, again, vaginal dilators may come into play there, but we work on teaching the woman and doing some scar massage to try and get that scar tissue moving. The great thing about scar tissue is it's very malleable. It responds to the stresses that are put upon it. And you just need to know to put stresses upon it. Right. And so
by stresses you mean like stretch?
Yep, gentle stretches, and that. So depending on, and at the evaluation appointment, we would see how are things moving, what part's stuck, what's not moving the way that it should be, and then come up with a plan for how do we stretch and move this tissue to try and get that freed up and moving more, and how do we do it in a very tolerable and comfortable way so that the body doesn't read it as, oh no, this is another painful thing that's coming here, and now the muscles are tensing up around it, like, this isn't a good idea. It's like, no, this is just gentle stretching to it.
So, Brooke, do you want to tell me a little bit about the patients that you see and how you evaluate and treat them?
Yeah, thanks for having me again. And we see a lot of women who deal with various types of bladder leakage or incontinence. And it can range from women who are just leaking a little bit when they cough or sneeze or laugh, or women who can't make it to the bathroom in time because they're having urgency and they're leaking on the way to the restroom. It can also be where they're limited in what they can do as far as their forms of exercise. We see a lot of women, unfortunately, who start to be less and less active because they are having bladder leakage. So maybe they used to love to do high intensity workouts, and now they've had to stop that because they're having bladder leakage and they're not comfortable wearing pads or that with it. And so they start limiting down how active they are, and we see that being honestly kind of a slippery slope for women, where they're being less and less active, and that affects their health and mental state. So incontinence can be a big issue that unfortunately isn't talked about as much, but it's very, very common. 1 in 3 women will experience bladder leakage at some point in their life. And specifically as it relates to our topic here, we have a visitor who wants to hear more about this.
Yeah, here's my dog Lou, but he's gotta go away. Go on, Lou. Go lie down, buddy.
I'll lay down right here.
Sorry.
No, it's fine. You're
sit,
so pretty.
Sit.
So bladder leakage is very common and affects many women. 1 in 3 women all experience bladder leakage at some point in their life. And one of the situations where it can be, so detrimental to a woman's relationship is the fear or the actual leakage of urine during intercourse. So that is, I hear a lot of women where they're really having some mental and emotional difficulties because they're either fearful that they're going to leak during sex with their partner, or they do, and so they avoid intercourse with their partner because they are so worried about what's going to happen in that situation. And so we work a lot with them to kind of rehabilitate their muscles and help make sure that things are working the right way so that they can have wonderful intercourse with their partner and not have to be worrying about leakage during that process.
Gosh, that sounds so embarrassing. So I am so glad we have people like you, because I do see in my practice a lot of women, both postmenopausal and premenopausal, who leak urine. Like you said, athletes, runners, since I'm a big runner, that would be really tough if I was leaking urine. So thank goodness for pelvic floor physical therapy.
Yes. And it depends on when your leakage is occurring, what the treatment might entail. And that's, so a lot of times urinary leakage is related to muscles being too weak. And the pelvic floor muscles specifically are the ones that help us to stop the urine flow. And if they are not as strong as they used to be, we can have some leakage occur, especially in higher intensity situations like running or intercourse or sneezing or coughing.
Right.
Oftentimes, weakness of the pelvic floor muscles is a big component of why women will have leakage. And so one of the ways to work with that is to teach people how to do, it's commonly referred to as a Kegel exercise, which is a contraction of the pelvic floor. You're pulling up and in like you're trying to stop the flow of urine or trying to hold back gas. Unfortunately, about 40% of people who think they are doing Kegel exercises correctly are actually not. So just being told to do some Kegel exercises oftentimes does not work out well for people because they're not doing the exercise correctly, and therefore they're not getting the benefits for the muscles, and so they don't see any changes happening and they continue to have leakage. But many people are unaware that you can go to the complete other end of the spectrum and have a muscle that's too tight or tense and have urinary leakage. So as I just tensed up my fist here, think about like my hand function here, okay? My hand needs to be able to contract and relax and stretch, and it needs to kind of do it independently for my fingers to be able to grab stuff and write in that. And so if I'm constantly holding a muscle like this, it's not a very functional muscle, and when it needs to contract or do more, it can't. It's just hanging out in a tense position. So sometimes women who are dealing with bladder leakage, like, I've been doing Kegel exercises for years, I always hold my pelvic floor tight. And your pelvic floor can actually end up all tightened up like this. And so we actually need to teach them and work with them like, hey, you actually need to relax those pelvic floor muscles first so that we can have motion there. Because just holding a muscle tight all the time isn't going to do the thing for us. It's not going to let the muscles do what they need to be doing.
So do you diagnose that by exam, digital exam, or do you diagnose that with the biofeedback?
So that works best. The gold standard is the single digit examination. Okay, that lets us really see how tense the muscles are. Are they resting in a shortened position? Can they move at all? Can the person relax them and stretch them out as well? Biofeedback can be helpful, but a biofeedback machine can also be fooled, because remember, the biofeedback picks up the electrical activity of a muscle. So if I've held a muscle tight like this for years, it doesn't take much electrical activity for my muscles to stay like this anymore. My nerves don't have to tell my muscles to stay tense. They just stay like this because I've just done it for years. And so on the biofeedback machine, it might actually look like the muscles are relaxed.
Oh, I see.
And so you can get a false sense that, oh no, everything's good there. So that's where the single digit examination of the pelvic floor muscles, either vaginally or rectally, gives us the most information as to, okay, are these muscles too weak or too loose? Are they too tight? So
what role does constipation play in all this, and are they linked, and how do you manage that?
Yeah, so constipation can definitely be linked into what's going on with the bladder. Everything is so close together down there that everything talks to everything else. And so especially if we've got tight, tense pelvic floor muscles, we can have difficulty having a bowel movement, and that because our pelvic floor muscles need to stretch, relax, and let go in order for us to properly evacuate that bowel movement. And sometimes people are actually tensing their pelvic floor more when they think they're pushing out, and they end up pushing against a closed door, and therefore we kind of get this backup of stool in the system there, and so they can get what's called functional constipation because they're pooping against a closed door, so to speak, and that their muscles aren't relaxing and letting go. We have a lot of fecal matter or poop hanging out in the rectum. It's going to push on the bladder, and now the bladder is going to be unhappy with it because it's getting something kind of pushing on it all the time, and so we can get more urgency or frequency where people are feeling like they have to go all the time because the bladder, one, doesn't have as much space to fill up, and two, is kind of, it's like having that little brother that's just there kind of punching on you the whole time. It's getting irritated, and so you can feel like you're needing to go more often.
Or when you're pregnant, the baby keeps pushing on the bladder.
There you go. There you go.
Going back to pregnancy, another analogy. So, interesting.
Yeah. So a lot of times when we're dealing with women who are dealing with urgency and frequency, we're definitely assessing what's going on with their bowel habits. And we find a lot of times with their pelvic floor muscles that they are too tight and too tense and need to learn to relax and let go a little bit, and teach them that before we work on strengthening. And that's a tough thing for some women to really let go of, because again, they're worried that they're going to leak or that, and so really a lot of education has to happen on how their muscle function is both helpful to what they need to accomplish, but also like how they are kind of dysfunctionally holding right now and how they need to potentially change that.
If you think you have any of these issues that we've mentioned, painful intercourse, leaking urine, constipation, any of those issues, you want to make sure that you ask your doctor to refer you to pelvic floor physical therapy. I do it all the time. Brooke works wonders. And sometimes we as physicians, we aren't thinking about pelvic floor muscles, but they play such a big role in so many things. So if you're not getting what you need or you have any of these issues, just bring it up to your doctor and ask for a pelvic floor physical therapy referral.
Yeah, thank you very much for mentioning that, because we do get a lot of women who say they've never heard of pelvic physical therapy and they've seen multiple physicians maybe before getting to someone like yourself, and that's never been given as an option for them. And so they're very thankful and very happy that they've finally figured this out and gotten to pelvic physical therapy, but you may have to be an advocate for yourself and
as you should always be.
Yes, ask for a referral to pelvic physical therapy. We know that many women are a little scared and worried and skeptical about what pelvic physical therapy might be, so we do offer a service that we call a discovery visit, where someone can call in and talk with one of our therapists, either myself or Jamie's our other women's health physical therapist there, either over the phone or come into our office. And there's no cost obligation whatsoever. Just come in and chat with us for 15 or 20 minutes. Get your questions answered. See if you are a proper candidate for pelvic physical therapy. Kind of learn a little bit more about what might be involved. So if you think you are someone who might be a candidate for it, but you have some questions, even if you're not local to St. Louis, feel free to give us a call and we'll try and point you in the right direction. Again, you can find our information on www.legacytherapystl.com, and we're happy to be a resource for anyone who's dealing with these conditions.
Thank you so much for coming and talking about such an important topic.
Well, I'm happy to, and thank you very much for having me today.
You're welcome. Bye-bye.